Visit WPS today to start unlocking potential.
Hello and welcome to the webinar, What Am I Treating? Case Conceptualization and Treatment Informed Evaluation in Childhood Developmental, Behavioral, and Emotional Disorders. My name is Stephanie Roberts, Business Development Manager for WPS. I'd like to welcome you to today's webinar. So when we develop a new test, we bring an author's idea to life, we answer a researcher's question, and we meet a clinician's need and ideally change an individual's life for the better at WPS. So I'm going to introduce today's speaker. Dr. Goldstein is an assistant clinical instructor at the Department of Psychiatry at the University of Utah School of Medicine and clinical director of Neurology, Learning, and Behavior Center in Salt Lake City, Utah. Sam is a board certified pediatric neuropsychologist, licensed as a psychologist, and certified as a developmental disabilities evaluator in the state of Utah. He has authored, co-edited, or co-authored more than 50 books, including 24 textbooks, as well as approximately 70 book chapters and peer-reviewed scientific research studies, and 8 psychological tests and assessments. I'd like to welcome Dr. Sam Goldstein to the presentation today. And at the end, I just want to let you know for the format, we will be doing a Q&A towards the end of the presentation. So whatever questions you put in the Q&A box, I will try to get to. Obviously, we've had some questions submitted ahead of time, so we won't be able to get to every question, but we'll do our best. Welcome to Dr. Sam Goldstein.
Oh, thank you, Stephanie, for that very nice introduction. And welcome to all of you. This is probably a full day seminar that we have an hour to spend doing it together. I will try in a broad way to cover this idea of why do we evaluate and what's the goal of evaluation. And we're asking the question a different way. We're asking, well, what am I treating? And if some of you take umbrage with that medical term, you could ask, who am I educating? Who am I working with? Who's the individual I'm trying to help? You can look at it in lots of different ways, but the question really is, what's the foundation for intervention? And particularly in our field, in clinical settings, in school settings, the focus by third-party carriers has been on treating, not on assessing. And less compensation is provided for assessment. We're always battling to get more hours to complete an assessment. And typically, third-party carriers, and even in the school setting, they want us to get on with the process of writing the IEP once a child has been deemed eligible for services. And the focus of that assessment is often on eligibility, not necessarily on generating the data that's needed to provide intervention. Stephanie mentioned that these slides will be available. They'll also be available on my website, where I have all kinds of articles and things for people to take a look at. I won't capture your name or sell it. I have, in response to people who took the time to send questions in advance, I have added some information and a few slides, and I will make this available to WPS and to my web person, so that if you want the final updated copy of the slides, it'll certainly be made available. And I made those changes late last night, so I apologize that there may be 1 or 2 slides as we go through this, if you're watching the slides, that you won't see. I will tell you from a disclosure perspective, I am compensated by WPS for this. I've developed tests, not only created by WPS, but others as well. I've authored books or edited books for a number of publishers. I'm the editor-in-chief of the Journal of Attention Disorders and co-editor-in-chief of the Encyclopedia of Child Development. And I am the chief scientific officer for Neurotech. Neurotech is a company that helps develop online kinds of assessments, both those in the cloud and those possibly even using VR. We've been experimenting with VR as an assessment tool. So just quickly, and I apologize if I go too quickly for some of you or not fast enough for others of you. What's this idea of treatment-informed evaluation? Meaning, should we start the assessment not by asking, what diagnoses does the child have, what eligibility is being determined, but should we start by asking what services are available? Because if we identify someone with need for which we don't have a service, have we really done them a disservice? So we'll talk a little bit about how I see evaluation. This clinic, I'm sitting in my office here in Salt Lake City. This is the 42nd year of our clinic. I started this clinic 42 years ago with a child neurologist. We've stayed open through COVID, given the population we see, 400 or 500 children a year, and some adults as well. About half have histories of brain injury or more serious neurologic compromise. And so the children I see are clearly much more complicated and compromised than what might be seen typically in clinical practice or in school settings. And so over the years, I think experience-wise, having evaluated thousands and thousands of children and supervised my residents and interns evaluating even more, I've come to appreciate a framework just experientially of what I think an evaluation process should undertake. And we're going to cover that today. We'll talk about some critical issues that I think you need to keep in mind, regardless of the setting that you're in. We'll talk a little bit about assessment components. This is not a marketing talk. I will mention some tools, but again, this is not a talk about marketing one tool or another. WPS has a half a dozen consultants who are very familiar with these tools and are available to help you if you're trying to find the right tool for the right question or create a battery of tools that you want to use. I'll tell you what I use, and I'll give you resources of where you can find out more about the kinds of tools that I think are important to use and why. And then we'll talk a little bit about a treatment plan, but we're not going to discuss treatment today. The focus is really on assessment. And we'll talk a little bit about how diagnosis or eligibility determination, which are the two primary things we do, is the start, not necessarily the end of the assessment process. So what is our primary goal? What's the primary agenda for us, whether we are educators, neuropsychologists, other mental health professionals, speech pathologists? I think the goal is to see the world through the eyes of the child, to have enough foundation that we can, in a reasoned and reasonable way, explain to stakeholders, whether it be individuals around the IEP table, whether it's other clinicians, whether it's other specialists like physicians who refer, can we explain through the eyes of the child what's taking place? Not with labels, not so much with descriptions of behavior, but rather from the child's perspective, what's taking place, so that we can then generate data that allows us to move forward in a seamless way. And in some settings, in some clinical settings, that process is broken up, that the evaluator will not be the one administering the treatment, or that the school psychologist will not be the one administering the interventions, or the neuropsychologist may not be the one working with the child in therapy. And therefore, it's critically important, since the primary means of communication between we, the evaluators, and the stakeholders who are then receiving the treatment or administering the treatment, it's critical that we provide them, and the primary tool we use is a report, that we provide them with a tool that enables them to move forward. And a list of diagnoses really doesn't provide that. And a statement saying the child's eligible for treatment really doesn't provide that. So I'm arguing that we need to be cognizant of how our data is going to be used, and that we start with treatment in mind. And I'm going to provide you with a framework for how to do this in a case conceptual way. And again, as you'll see, as the years go on, we as evaluators, and I'll from this point refer to us in a generic way, that we as evaluators are tasked with a greater and greater job. That what once was a handful of short instruments, intellect, achievement, maybe motor and perception, now has grown to a much broader set of tools, because even clinical psychologists administer neuropsychological measures in their efforts to try and appreciate process, not just product. And that the behavioral tools we use now ask more than just symptom questions, but ask about process questions, behaviors that we report fall under the umbrella of executive functioning. And in an assessment model that we now use very widely, we're asking not just about strengths or not just about weaknesses, but about strengths as well, and appreciating that you need to know both. And in fact, in the long run, strengths are better predictors of outcome over time than liabilities. So the school psychologists, the clinical psychologists, the neuropsychologists that we are training today, their assessments will be far broader and more in-depth and generate even more data that has to be somehow made sense of than even what we're doing today. And I think we'll talk a little bit about the history of diagnoses, internalizing and externalizing conditions, the history behind special ed categories, and why the schools, when legislation for IDEA or IDEIA, the Individuals with Disabilities Education Act or Improvement Education Act, why, and I served on one of those committees for the second reauthorization, why we shied away from diagnostic labels and instead focused on eligibility by impairment. Very different process. And yet some of the same terminology is used, the same diagnostic labels are used. Somebody asked a question about how to integrate diagnoses into school settings. And I don't know that that's a need. I don't even know that that's appropriate. In the schools, we focus on eligibility and the impairment that underlies your eligibility and what we can do about it, and not so much on diagnostic labels. And so I think you have to start with this TIE framework. I think a patterns of strengths and weaknesses approach is essential. And we're slowly beginning to ask what's right about a child and not just what's wrong. A tool that WPS published of mine, the RISE, the Risk Inventory and Strengths Evaluation, is one of the few tools that has created an algorithm to not just measure adolescent risky behavior, but also measure adolescent strength, emotional balance, sense of mastery, interpersonal strength. And then we'll talk a little bit about these tools and why the gold standard has increasingly shifted towards questionnaires that are completed by stakeholders or by the child or adolescent themselves, and less so upon face-to-face testing. So initially, we're going to talk about tools that are used for a diagnosis, meaning a tool that in the title says depression or anxiety or autism. And those tools are fairly straightforward. Again, questionnaires don't diagnose, but we do in fact use the tools to gather symptom reports and broader behavioral reports. So all symptoms are behaviors, but not all behaviors are symptoms of certain conditions, if that makes sense. And these tools extend beyond the Children's Depression Inventory, the Revised Children's Manifest Anxiety Scale, the Autism Spectrum Rating Scale that I developed with Jack Naglieri. These tools ask not just about symptom questions, but about the broad kinds of behaviors that children with these conditions develop and demonstrate. And then secondary tools, tools that tell us about broader functioning, resilience, trauma, attachment. These are not used to create a diagnosis per se or to determine eligibility, but rather to provide a broader foundation understanding the child, both in risky ways and in asset or positive ways. And then third tier tools like self-concept. WPS has done a second edition of a self-concept scale. that's been very widely used, or measures of impairment. Dr. Naglieri and I have a tool, others have tools that ask not just do you have a symptom or a behavior, not just the setting that you see it in, but does it cause impairment? Does it cause problems? And again, these two sets of tools, these secondary and third tier tools, I think are essential in assessment because they lead us down the path to treatment, not so much because they enhance our ability to make diagnoses or to determine eligibility. And so that's the takeaway message. And a lot of us who've been doing this for a long time, we get set in our ways. And for those of you who've done it a long time, all I'm trying to do is get you to think a little bit differently about what you've been doing, and then ask, do I need to do it a little bit differently? So we collect data about thinking, learning, feeling, behavior. We collect that data from questionnaires, from direct assessment of the youth, from self-reports by the youth. And then we look at how these phenomena interact with environmental factors. You know, a child with mild patterns temperamentally of impulsivity in an environment that is much more chaotic, responds in an aggressive way to childhood challenges, will be more symptomatic in their presentation than a child with a similar pattern of mildly vulnerable temperament being raised in a consistent, predictable, patient, authoritative environment. So the environment plays a significant role. And when we collect normative data, for those of you that may or may not be aware, on tools that are used across the country, we try to match to the census so that we wash out differences. I'll tell you something interesting. Level of parent education is a significant variable in determining the number of complaints parents will have about children. That the greater educated a parent is, the more sensitive they are to differences in their child's presentation. I'm not suggesting that they create problems. I'm just pointing out they're more sensitive in identifying challenges. And as educational level decreases, parents are less sensitive to that. And so a good tool is built to match the census in an effort to try and wash that out so you don't need normative data for every level of parent education. And then I think a good assessment concludes with an understanding of etiology, what's driving this, not just what do we see, but what's driving it, and prescriptive interventions. And keep in mind that for many of the DSM categories, etiology is not an issue. You don't have to define the cause, whether it's genetic, traumatic, biological, experiential. You just define the symptoms and determine whether they meet diagnostic threshold. And then I think we also focus on limitations or impairment because again, symptoms and symptom presentation and severity of symptoms doesn't always tell us how functionally limited somebody may be. So here's kind of how I see it. I always start out by looking at records. And over 45 years of doing this, I'll tell you now, I just finished putting together a report for a child I tested yesterday. This child had been tested twice before over the last 7 years. And I have included each of those assessments as an appendix. I didn't just read them, and I didn't just paraphrase or cite them in the body of my report. I'm actually including them as an appendix. Now, why am I doing that? Because I've come to appreciate that the moment I'm seeing a child, one of the most valuable things I can provide, again, I see, quote, Job's kids, meaning I see kids with multiple risks who've been treated and evaluated in multiple settings and probably had multiple school assessments as well, that in creating a document that not only summarizes but includes critical records from the past, I'm creating an invaluable resource for parents and other professionals moving forward. That this singular document, and we do everything electronically now, so creating an 80-page PDF of which 25 pages is a report, and the remaining 50 or so pages are essential records, electronically is really not a problem. It's not a large wad of paper that will now burden the child's file at school. And so I think including records for me has now become important. So I wanted to see those records even before I take a history. And in a school setting, you look at what's available. I use questionnaires because in a clinical setting, ICD and DSM require symptom reports across at least 2 settings. Typically, that's parent and teacher. And so I start with a broad spectrum tool, whether that's the Conners or the Basque or the Achenbach. I think the Conners and the Basque are better and broader than, say, the Achenbach in understanding a broad spectrum of potential symptom presentation. But I think you need a broad spectrum tool. And then based on the broad spectrum tool, then I decide, am I going to use a narrow spectrum tool if I suspect autism or depression? Am I going to use second tier tools that look at things like executive functioning or resilience or adaptive behavior? Am I going to look at third tier tools that look at things like impairment? And I want the parents to complete a history form. I have made available the history form that our clinic uses, and WPS has graciously created a PDF version of it that can be completed by a parent online or offline, that can be printed and completed by hand. And for participating in this evaluation, it's going to be made available to all of you for free. I'm not selling it. There was a time when we did. All I'm asking is that you don't take your name off and or take my name off, excuse me, and put your name on. This is the history form that I've developed as part of our clinic, and I would appreciate it if that's how it's presented to others, and you're welcome to use it. And then I meet with parents. I try and reconcile differences between parent raters. Look, when we have elementary school children, we get a rating from a singular teacher. As we have middle and high school, the more raters you get, the more differences you get, because subjects are different, teacher styles are different, and you have to try and reconcile those differences and explain them, not explain them away, but try and understand them. Big differences sometimes between home and school. And in the past, we would say if school sees a problem and parents don't, then the parents their eyes are closed. But now we know it's not true, that some kids function better in the school environment than home, or vice versa. One of the big challenges is reconciling differences when parents are in different households or in the throes of a divorce. And parents have their own reasons for why they may respond to our questionnaires in one way or another. And it's our job as clinicians. AI is not going to be able to do this. It's our job as clinicians to be able to filter through and integrate that data. And then if you're in a school setting, you need to have real world observation of the child, because often what you see in the real world helps you better understand the data you've collected and supplement the data. And then you got to see the kid. You got to take a history. You got to do a clinical interview. You have to try and see the world through the eyes of the child. So, and I'm appreciative that I think I started at 10 after the hour. So I'm tracking through to make sure we don't run out of time. Let me go back here a step. So, this is the logical course. I want to know your history. If it's a teen, I want to know whatever pre-vocational activities they're engaged in. I want to know their personal or psychiatric history if there's been a trauma or other injury or developmental disorder. For those of you that are in clinical or even school settings, I would encourage you to take the time to understand the most common genetic disorders. You don't have to know mucopolysaccharidoses, but you do have to know Fragile X and Marfan's and Turner's. And you need a desk reference. Cecil Reynolds and I have edited 2 textbooks as a desk reference on common genetic disorders that affect development. You don't have to have the book, but you have to have some resources, and you have to know symptom course over time, and you have to have a method for integrating the data. Just quickly, if you're looking at the slides, I added this last night. I had a revelation in St. Augustine, Florida. where doorways are very short because people were short in those days, and they didn't waste any resources on building doorways. The world operates on a normal curve, and we build an educational system in a world for the middle. And when I meet a kid in an effort to try and understand that, the first thing I do is the bus test. Now, where'd that come from? Well, you know, the earliest diagnoses for kids were fairly limited and focused on Achenbach's framework of disruptive and non-disruptive problems, how the child's behavior affect us. And so I asked myself, if I was on a bus with the child I'm testing, could I sit next to them? And some children are disruptive and annoying, and it's hard to sit next to them. And you begin to think about how the world responds to that pattern of temperament. And other children are very passive and sit there reading their book. But as you get to know them, you worry about their mental health. You worry about their welfare. And since this introduction in the 60s, we've cut the same set of symptoms into smaller and smaller parcels. And so it's not surprising that when we're using diagnoses, children who received one diagnosis in the past now receive 2 or 3. You know, that we've broken it up. Eligibility hasn't really happened that way because we've held the line on the 13 or 14 eligibility categories. And we haven't created 30 or 40 eligibility categories. But these are the 2 things we do as psychologists. They're dimensional. The majority of what we do as psychologists is dimensional. These 2 are categorical. And just to kind of let you see, we're not going to spend much time on it. You know, this is kind of the disruptive road. Children begin with difficult temperament. Temperament are those qualities kids bring to the world that are not so much caused by experience, but by unfolding of genetics. And attention deficit is kind of the early emerging pattern. Kids whose early temperament is excessively restless, inattentive, impulsive. And for some, that progresses to being oppositional, on the mind, out the mouth. Some kids are oppositional, don't start with ADHD or difficult temperament, but by far the majority of kids on this continuum start with difficult temperament. And then conduct disorder, which is a limited list of behaviors that violate the rights of others, that are sometimes confrontational or non-confrontational, and we call that conduct disorder. And not all kids with oppositional defiance progress to conduct disorder, but a significant percentage do. So when I take a history for parents, I consider this. What was the child's temperament by description of behavior by parents? And it's in the history form. And then was the temperament sufficiently disruptive that it seems like the child did have the symptoms and the pattern of behavior characteristic of attention deficit? And 60 to 70% of those kids then meet criteria for oppositional defiance. If we had more time, I'd show you the data, but it's at least 2/3. And then maybe half of those progress to conduct disorder. And conduct disorder seems to have a lot more to do with experience and less with genetics. Oppositional maybe is 50-50. Attention deficit is clearly a lot higher percentage of the genetics of your temperament versus how your parents respond. And then this is the non-disruptive. It's not really a continuum. You have temperament, the shy, slow to warm up child, and the vulnerability of depression, which is a sense of hopelessness or helplessness, and anxiety, which is lack of confidence in predicting outcome. And for me, this process of treatment-informed evaluation, the history with the parent, it takes me about 2 hours, and some of you may not have that time, but it's an educational exchange. I'm gathering data about the child, but I am simultaneously placing that data in a Piagetian way, right? When you think about accommodation and assimilation, I'm putting it into a framework and then giving it back to the parents, helping them better understand. So when we talk about depression, we talk about a sense of helplessness or hopelessness. And historically, is that something the child demonstrated very early on, a pattern of temperament, a trait, as it were, or is that something that the child developed over time in consequence of repetitive failure or some combination? And the same thing with anxiety. Is this a sense of uncertainty about outcome, worry about danger that developed early on, a 2-year-old afraid to separate from mother, excessively fearful of clowns or other kinds of phenomena, or demonstrating sensory sensitivity to noise or visual stimuli that makes them uncomfortable and anxious? Or is it something that developed over time as a consequence of some adverse experience? And depression and anxiety, while they're two different categories, really are an underlying phenomena, a singular phenomena, because in large-scale population studies, you don't find one without the other. That people who are worried and uncertain about outcome often feel helpless and hopeless, and people who feel helpless and hopeless struggle about feeling confident about outcome. I can tell you that I think emotions evolved because they had safety value. They kept us alive. I don't think depression does. And I think depression, at least in my experience, is often a consequence of other adversities that drive people to feel helpless or hopeless, whether it's learning, whether it's social, whether it's excessive worry about safety or outcome. At some point, those phenomena lead people to be depressed, which is why the incidence of feeling helpless and hopeless being depressed is so much higher in children with developmental and learning problems. And so here's how I see the world through the eyes of the child. I take a history, I use well-validated tools. I know this is a bit redundant. I administer face-to-face tasks. I try and focus on what is the child seeing? How are they feeling? What are they doing? You know, most kids are doing the best they can. A boy I tested yesterday who has a very aggressive pattern of temperament told me that he can never control what happens to him. And I asked him, well, help me understand. What do you mean by that? Can you control whether you talk to me? And he said, oh, yes, I can control those things, but I can't control the bigger things. And so when I can't control things, then I try and control things. I mean, it was very interesting listening to this boy's insight and the process by which he arrived at his conclusion that the only way to get what you want in the world is to take it. And if people won't give it to you, then you take it by force. I think understanding the child, being able to paint a picture of the child's life to the parents or to the educational team or to the pediatrician or psychiatrist, I think it's critical. I think the issue is not the diagnosis per se, the eligibility per se, and I know I've repeated this, but it's taking the time to see the world through the eyes of the kid. I have a clinical interview format that I use, and I'm hoping WPS will do the same thing with this clinical interview format as we've done with the history form, because people will ask. I do make it available. It's questions I've gathered over the years. It's a qualitative tool. I'm arguing here that we shouldn't get lost in the quantitative weeds. We shouldn't assume that something that isn't norm referenced, that something that is just descriptive doesn't have value. It may not be as valuable in the diagnostic process or the eligibility process, but it's clearly valuable in the treatment process. Understanding from the child's perspective why they do what they do and why they see what they see. I mean, this is what therapy is about. Therapy is not about a checklist or a contract or a parent's helping a parent fill out a form at home to watch the child's behavior and provide rewards or other consequences. No, that's behavior management. Therapy is about helping an individual, regardless of their age, better appreciate who they are and why they do what they do, and then helping them make a decision. Are you happy with this, or do you want to do it differently? This boy I saw yesterday, when I asked, are you happy with this kind of behavior, said, I'm not happy with it, but that's all there is, and I can't do anything else. And until I can convince him there are other options, then seeing him in therapy is really a waste of time. Unless I see him in therapy to try and change his attitude. But maybe he doesn't want to do that. So I do think it's critical to, when I say see the world through the eyes of the child, to really be able to appreciate that and explain that to stakeholders, which is what I spend a big part of my time doing when I discuss with parents and educators and other treaters what I think is going on and why I think it's happening. And I want to know about the person conceptually. Holistic, the term holistic sometimes gets a bad rap, but I want to know not just what's wrong, but I want to know what's right as well. Where are their strengths? And what assets can we bring to the table to help them cope with whatever liabilities they're experiencing? So here are some critical issues. I'm going to put them all up there so you can see them. And the one we've already talked about, assess for intervention. What about the next one? Sensitivity versus specificity. I don't know how many of you remember that, but a sensitive test is willing to have false positives. A sensitive test says, I want to find everybody who needs help, even if I identify some people who don't really need help as needing help. A specific test says, I only want to identify the people with the problem. And I understand that in doing so, I will reject some people who have the problem to a milder degree. When we determine eligibility, when school districts set discrepancy criteria or other kinds of formulas, we are making an effort to balance sensitivity with specificity. When we say you need 6 out of 9 symptoms of impulsivity for the diagnosis, or 5 out of 9 symptoms for a diagnosis of depression, what we're saying is that we're trying to balance sensitivity, because if we were just sensitive, we'd say if you have 3 symptoms, you got a problem, we're going to help you, even if some of those people don't meet full diagnostic criteria. And if you say, oh, I'm going to be more specific, then you say, well, I'm going to really hold people's feet to the fire. And unless I really see that symptom, I'm not going to check it off when I make the diagnosis. And as treaters, I would encourage you to be sensitive to help, but specific to assigned diagnoses. In some parts of the country, certain diagnoses skyrocket at times. In California, among junior and senior high school students a number of years ago, the diagnosis of ADHD skyrocketed because it would qualify you to take accommodations when you take college entrance exams. And all of a sudden, students who maybe had mild problems and never really needed any extra assistance, now in a sensitive way were identified, well, you have the problem, because that way I can give you the accommodation. Positive versus negative predictive power. What does that mean? What's the probability that the presentation of a symptom or a behavior proves you have the condition? What's the probability that absence of it proves you don't have it? And some behaviors or symptoms have positive but not negative power. For example, CPT tests that are used to evaluate attention and impulse control. If you fail it and you took it, you really do have problems with impulse control. But if you pass it, you still may have impulse control problems in the environment, but you're just sufficiently motivated that you worked harder on the test. Does that make sense? So some have higher positive, some negative, and some symptoms, presence and absence, are both. And our diagnostic symptoms, we don't use that. We don't use an algorithm that says, hey, this symptom's presence always proves you have the condition, or this symptom's absence always proves you really don't meet diagnostic criteria for this condition. It's something to think more about. The disruptive and non-disruptive continuum, which we've already talked about. I mean, again, the earliest diagnostic descriptions were behaviors that disturb adults, behaviors that don't. I think it's important to keep low incidence conditions in mind. Things like Fragile X, often genetic conditions, or other medical conditions that may be responsible for why the child is struggling. And as clinicians, often we don't spend a lot of time studying those. I would encourage you to do so. I also think you have to consider protective factors. What is resilience? The ability to function well over time. I've talked about it in others of my WPS webinars. I'm going to jump ahead here. There. Look at, and I'll go back. So look at these qualities. I apologize, that slide seems to have collapsed itself a bit. These are protective factors. Kids with more engaging temperament, kids, an IQ there, I'm talking about critical thinking, not, for example, necessarily a language-based or an information-based IQ. Positive self-concept, impulse control, an internal locus, faith, humor, helpfulness. These qualities seem to insulate us under adversity. These qualities in the child increase the likelihood that whatever challenges they have, they may fare better in the face of everyday life. When I take a history, I go through these qualities with parents. I've had parents say, boy, my kid, he doesn't sit still, he runs all over, but everybody loves him. Why? Well, because he's very social, and even though he's running all over, he always has a smile on his face, as opposed to other parents who say, you know, my child is so disruptive, he runs all over and people can't stand him because he gets into things and because his impulse control is poor. And I think you want to know these protective factors that enhance better functioning within the kid. And here are some, just quickly, that enhance functioning, but they're in the environment. And again, I'm not saying smaller families are better. It just is demonstrated. Mothers who don't have mental health problems because they are the primary caregivers. A charismatic person in your life, having a close bond with someone. You know, a child not long ago, when I asked him, you know, did he think things would be okay in his life? He told me yes, and I asked him why, and he said, you just have to know my mom and dad, they really love me. That sense of connection, that sense of security, especially in the world we have now and will have moving forward, is critical for a child. Living above the poverty level, having a friend, involvement in pro-social organizations, doing things to help others. All of these are protective factors. And when I take a history and I take it with an eye towards how am I going to organize a treatment or an educational plan for this child, I want to know these things. And I understand in some settings, it's very difficult for you to gather this data. You don't have the time. Parents don't necessarily want to take the time to report it to you. But I think you have to try. I think these factors are critical. Now, if I go back here and see some of these show up, right? We've already touched on religion, locus of control, sense of humor. You see them, they're already there. Socioeconomic status, it's a variable. Social relations, having at least one friendship. And we've talked about briefly categories versus dimensions. I'll ask you to think about it. It is a dimensional world, and everything we do as evaluators is dimensional. The scores on our neuropsych tests, on our achievement tests, on our academic tests, the scores on the questionnaires we use. Everything is in a dimension. Even the history you take, you think about how these parents present relative to the parents you've seen before. And yet, we're asked to then take all that information and distill it into a category. And then as soon as we've done that, we jump back to the dimensional world, because the way we organize our interventions and the way we measure success is dimensional, not categorical. I also think it's important to understand the difference between a symptom versus a consequence. And again, as I mentioned, all symptoms are behaviors, but not all behaviors are symptoms. And not all behaviors are consequences of symptoms. So I had a parent, for example, tell me that she didn't believe her child had ADHD. And I asked why, and she said, well, the boy next door has ADHD and he killed a cat. So the consequence of that boy's impulsive behavior, we don't know if maybe he truly is antisocial, but of his impulsive behavior, the consequence of that is a cat died. But that's very different than saying cats dying is a symptom of ADHD, or animals being abused is a symptom of ADHD. Just yesterday, I took a history from the family of a 6-year-old boy, clearly has high functioning autism. And he annoys the dog, but he doesn't do it because he's mean or nasty. He doesn't do it to get a reaction from the dog. He does it because he can't take the dog's perspective. He doesn't know what the dog likes or doesn't like. And despite all the discussions that his family has had with him, he still has a hard time appreciating that. He can't put himself in the dog's perspective, which is what the core of joint attention and taking the perspective of others, theory of mind, which is what the core of that is about. And I think you have to accept a moment in time. Where the child is today may or may not be where they are a year or 2 or 3 years from now. And I can tell you, I know that from seeing kids over many, many years and watching sometimes changes that I wouldn't have anticipated. And I think there are no shortcuts. And I think, as I pointed out, you have to know the context or the environment. And I think that the pathway that leads to positive adaptation despite high risk and adversity is complex. And I don't think there's a generic bullet that's going to make a difference for everybody. So I think you got to take a history. You got to form opinions. You got to look at ability, knowledge, and skill. What do I mean by that? Abilities are hardwired, not that biology is destiny. So we're talking about things like memory, planning, sequencing, association, the underlying processes that contribute to the rate at which kids will acquire knowledge and manage that knowledge. And knowledge is anything you learn by experience. It includes language. You don't speak to a child, they won't speak. And skill is a verb, skillfully using your ability and knowledge to solve problems. And this is how I think the brain works. I've done other workshops on this. This is the model, Luria's model that Jack Naglieri and J.P. Das and others use, Alan Kaufman as well. Planning, attention, not paying attention, but being alert to details, simultaneous or critical thinking, and sequencing. I have a new book authored with Bob Brooks called Tenacity, the 7 Instincts That Make Us Human. And we go through this in terms of how simultaneous or critical thinking evolves and how these neuropsychological abilities play a role in our lives. So, step 1, get a history. Step 2, I think you need to know about impairment. So, impairment can include an impairment scale. It can include qualities of executive functioning. I mentioned our risk inventory. I think you also have to administer a broad spectrum tool. I use the Connors. The BASC there should be in a blue color as well. It's a very good tool. And then I think there's questions for the history. I'm seeing that I have about 20 minutes left. So I want to get to a case here. But this is what I use in the history. BIND is a bilirubin-induced neurologic disorder. And most people don't know that if children have high bilirubin and you don't bring it down, it can cause both short and long-term developmental conditions. So I ask about pregnancy and birth. I want to know about temperament. I want to know medical history. You'll see the history form that the WPS will make available to you that kind of goes through that. I'm going back here. So broad spectrum tool. And then narrow spectrum tools. So narrow spectrum tools looking at disruptive, non-disruptive conditions. So there's the ASRS, there's the ADI, there's the social John Constantino's scale, which is a very good scale. All of these are available from WPS. There's the ABOS, which measures adaptive behavior. So adaptive behavior for me means, do you know how to do it? And Tom Oakland, who's the author of this, who unfortunately passed away a number of years ago, we had multiple interesting conversations and eventually agreed that adaptive behavior is, do you know how to do it? And impairment is, do you do it? So watching a child not use a fork while eating tells you they're impaired. But you then need to decide, do they know how to do it and don't? That's impairment. or do they not know how to do it? That's a lack of adaptive behavior. And for those of you who use the third edition of the ABOS, you know the instructions for this version are, if the child doesn't know how to do it, score 0. And if they know how to do it but don't do it, then assess their presentation. There's the mask, which is a very good Sargent's measure of the mask. I think it's Sargent. I'm blocking now on his name. Maria Kovac's Children's Depression Inventory. There's the cognitive assessment system that we developed that ask more narrow symptom kind of problems. And then these are more face-to-face kinds of tests. And I really like the Montanaro that WPS markets as well as the ADOS. These are structured interviews. And that's step 5 there, looking at ability testing and achievement. So things like the Kaufman and the CAS, they measure neuropsychological processes. And you have to decide what to give based on that history. And then I think you want to know about resilience. There are a number of scales. You want to know about personality using base rates, not just averages. And then you want to know about the kid, including projectives. I really like the Roberts test that WPS markets. They pull a little bit more for real world situations than say the TAT or the Rorschach. So then I do a day in the life with parents. Why'd you come see me? What are we looking for? Then I say, from the time your kid wakes up till the time they go to bed, what forces impact them in their biology, in their temperament, in what they've learned, in their mindset, in the ideas and mindset of the people around them, in their cognitive development, in their level of achievement, in their socialization, in their insight. And I just take them through a day in the life. And here's why I think these things are happening. That's how I do it. So I try and talk about process. And the last thing I talk about is a label. And then I try and explain for each of the areas in which I think we have an understanding of why the child's struggling: on the playground, learning to read, doing their homework, whatever the case may be. I then focus on, here's the underlying processes that I think contribute to the problem. And sometimes there isn't a lot you can do about it. Sometimes there's a lot more. And I begin to offer parents ideas towards resources and try and do it in an organized way. I don't cut and paste 30 pages of recommendations that we can download from the web. 30 years ago, 40 years ago, you did that. You had lots of handouts for parents. You had lots of suggestions. But nowadays, I think it's fairly transparent when you give a parent a report with 30 pages of really cut and paste suggestions about what to do. Most parents realize that those are kind of generic templates that are included, at least I think. And I think you're much better off spending your time helping them see the world through the eyes of the kid, and then saying, look, your kid has problems learning to read because of their struggle with sequencing. And here's a reading program that's AI-based, or 2 or 3 that I encourage you to explore, that will try and compensate or address for that. And if I think this worth the time to try and remediate the neuropsychological weakness, well, sure, here are some activities that you can do that hopefully will help your child be better at sequencing. And here are some compensatory strategies you can do to help them sequence better as they're trying to learn, to make more of the abilities they have. Here's a quick case study, and it's hard to offer a case study and look at how do we measure the effectiveness of our intervention. So I picked one way of doing it, and you'll see what I've done here, but there are a lot of ways to do it. Here's a kid, that's not his picture. That's a picture that you can use if you pay a fee. And this kid's gotten a lot of help. He's been diagnosed with ADHD, was taking a medicine, but still struggling. His mother says, you know, his ADHD symptoms in a chronological way started early and have affected his life. You know, he's passive now. He avoids interactions with others. His hygiene is a problem. And is that the impulsive outcome of ADHD, or is there something else going on? His mindset now is, leave me alone. I was born with half a brain. I can't do anything about it. And he's very disruptive when told what to do. He struggles to learn from experience. You know, when you look at parent-teacher questionnaires, if we had time, we'd look at them. You can see the consistency in both his disruptive and non-disruptive challenges. When you look at his testing, you see he has trouble with processing speed, takes him longer, slow isn't fast enough. He has trouble with planning and organizing. He has trouble with attention, but he's got normal intellect. So it's not an intellectual problem per se. He has struggles with reading and math and written language, in this case using the Woodcock-Johnson. And the question is he behind for lack of practice for proficiency, or is he behind because this is as fast as he can go, even with opportunity? And when I interview him, very limited insight, doesn't report a lot of symptoms of depression or anxiety, despite the fact that those around him describe those kinds of symptoms. And in the end, I focused on, leave his diagnoses out of it. In the end, I decided he had ADHD, he had internalizing problems, at the very least consistent with depression. He had social pragmatic problems, clearly didn't meet full syndrome for autism. So he had a lot more going on in terms of diagnostic descriptions than just ADHD. And here I'm using the RSI, the rating scale of impairment, to look at his level of impairment. So there's his level of impairment when we started with him. And this tool we built, David Herzberg, Jack Naglieri and I built this tool on the World Health Organization standards for impairment, the WHODAS, and it looks at 6 categories for his age. And you can see, if you look at percentiles, higher scores are not good because we're asking about bad things. He doesn't have any impairment in mobility, right? And when he's doing family things that he enjoys, he's not terribly disruptive with the family, although still 90th percentile. But in all the other areas, he's very impaired relative to kids of his age. Again, not asking, does he have symptoms, but do they cause functional impairment in everyday life? There's a description of the treatment targets from what the parent described. If you can see that, you know, lack of organization, struggle to keep up academically, struggle to problem solve effectively. We took each of these descriptions and tried to flesh them out in terms of how they affected him and what could be done about it. There's treatment targets you see with for domestic or self-care. And his self-care trouble was an issue, and I decided it was more based on his impulsivity and his helpless, hopeless attitude than some kind of autistic-related problem. I talked to his parents about a day in his life. I had a meeting with his school team, and then I had a meeting with he and I through Zoom with his therapist. One of the advantages of the last 2.5 years is that meeting virtually has become acceptable. It's a lot easier now for me to have school meetings. And for kids like Joey, who already had a therapist, and the therapist made the referral because Joey's lack of progress, I can get on with Joey and the therapist, and together we can talk about what we learned in this evaluation about his strengths and about his challenges and about his mindset. And again, the initial goal is convincing him that things could be better if he did things differently. The physician adjusted his medicine, both the dosage and time, still just a stimulant. We began to track him to consider what he would do maybe after high school. So we started looking at a transition plan for him, which most of the time the schools wait until kids are in their junior year. I asked the parents if they would work with a behavioral consultant so that the therapist didn't have to juggle two hats. The therapist expressed concern that a lot of the time in therapy was spent with Joey's parents basically complaining and feeling helpless to do anything about his problem, and then the therapist feeling somewhat put on the spot to fix Joey. And we set up a response cost. If you know response cost, it means you can lose what you have. In this case, he was given a fixed amount of allowance, and he started with all of it, and he worked to keep it rather than earn it, which is the response cost model. The IEP at school was rewritten. There was more of a focus on strategy, instruction, and social relations, and the school psychologist was brought in to focus on social development. Pre-post RSI scores. So if you look, this is post, the T-score is still above the 98th percentile, but it's down over a standard deviation. Social, down a standard deviation. Mobility wasn't a problem. Domestic, down a standard deviation. Family, down a standard deviation with a T-score of 50, exactly average. Self-care, again, these are still problematic, but a pretty significant improvement over a 3-month period of time. This is one way of measuring change using this tool. It's not the only way. I do think that it's harder to use scales that are developed for assessment to monitor treatment over time, because a lot of the scales ask about certain behaviors, not about impairment. So saying the child's attention is better or their impulsivity is reduced is not the same as saying that they're getting more work done. And if you want to know about getting work done, that's what you got to ask about. So just to quickly conclude, and again, this is a much longer topic, but I hope that I've at least stimulated you who've been doing it for a long time to stop and ask, what am I doing and why do I do it? And do I want to keep doing it this way? And those of you that are new, to appreciate that we understand the burden that we're placing upon you to see the world through the eyes of the child, not just to determine eligibility or make a diagnosis, but to truly see the world both for the child's strengths and assets, to truly understand on a process base or basis where the child's strengths lie on from a biological perspective in their development of abilities, where their weaknesses lie, how their level of achievement has progressed, what their mindset and attitude is. Again, to see the world through that child's eyes in a holistic way. So I think you got to start by appreciating it's a complex process. You're not always right, and over time your opinions may change. I think, again, determining eligibility and diagnosis is a limited process. I had a reviewer for one of the insurance companies tell me that I didn't need 4 hours to evaluate a child with ADHD, despite the fact that they have high comorbidity. They said, look, the evaluation of ADHD requires asking 18 questions. That shouldn't take you very long. And it's really a failure on that person's part to appreciate what we're doing here. And I think kids rarely present with one problem, one isolated challenge, one isolated liability. And I think that symptom relief is valuable, but nurturing assets over time is far more valuable to pave the road into an adult's future. And that's why we do it. Why do we do this? Because we're trying to make a difference for the 15 or 20% of the population that are compromised in their ability to struggle and function into adult life. If you scan that QR code, quick reference codes, QR codes, fascinating. They hold 100 times more information than a barcode. So they've become more and more popular. That'll take you to my website. I am collecting data for a new tool, DMDD, disruptive mood dysregulation. If you're interested in participating or have an idea to write a chapter for a book for my DMD textbook, let me know. There's my TED Talk. I'm on all the social media. I have a TikTok now called Common Sense Science. I rail on some of the really wrong information that is promulgated by pseudo experts on social media, particularly on TikTok and other social media. So thanks for spending your time with me. You can always reach me through my website. I'm happy to give you feedback or opinions or tell you what I think.
Thank you very much, Dr. Goldstein. We are not finished though yet, so I don't want people to jump off. So whenever we hit this thank you slide, we get a drop off. But please know we're about to do a question and answer for the questions that were put in the Q&A and some questions that were given ahead of time. So if you could just hang on, this webinar does go until 11:30. So if you could just advance the slides for me, Sam.
And I apologize, Stephanie. We moved this slide to the end. But somehow
no, it's okay. No, it's perfect. It's fine.
Back.
No worries. All right. So one thing I do want to tell you, it's very important, is that we have some other webinars coming up. So let me just tell you about that very quickly. We are going to put a link in the chat box. Dr. Rogers is going to do that in just a second. But we have a dyslexia series coming up. We will be doing dyslexia with Dr. Nancy Mather. The first webinar will be on October 5th, and that's Dyslexia 101, Understanding Dyslexia and Its Impact on Reading, Spelling, and Self-Esteem. The second webinar will be November 2nd, Best Practices in Dyslexia Assessment. The third webinar will be December 7th, and that will be Challenges in Assessing Dyslexia. And Dr. Rogers has put those links in the chat for you. One of the things that is important for you to know also, WPS is going to be publishing what's called the Tests of Dyslexia, and it is authored by Dr. Nancy Mather, Dr. Steve McCullum, Dr. Sherry May Bell, and Barbara Wendling. So anyway, just take a look out for that for 2023. That will be coming.
And if you've never heard, can people still hear me?
They can still hear you. Go ahead.
All I want to say is, if Nancy and I have written 3 books together, and I've had the wonderful pleasure of working with her on projects over almost 40 years. If you've never heard Nancy speak, this is a wonderful opportunity to do so. I will tell you, she, from my view, is the foremost expert. She's the godmother of the Woodcock Johnson. And if you've never heard her speak, don't miss this opportunity.
Yes, she's a very fantastic speaker. The other thing I want to say, if you have questions that are assessment related, we do have 5 assessment consultants ready and willing to help you. This is a regional map to show where which states they consult with. And the next slide, go ahead, Dr. Goldstein. These are the assessment consultants that are available to help you. We also have Dr. Ann Rogers, who is a business development manager for clinical and other related areas. But if you want to contact any of those individuals, you can email consult@wpspublish.com. If there is anyone that needs consultation in relation to general education assessments or assessments for special education teachers, you can contact me, Stephanie Roberts, Business Development Manager, at the same email address. Okay, we'll go to the next slide. All right, so we are offering a back to school discount. It's 10% off of the WPS assessments with the code B2S22W1, and that's at checkout online. You can also contact your assessment consultant and give them the same code. Okay, the next slide is resources. We have the WPS online evaluation system. Many of our assessments are online. We have rating scales online. We also have easels and other types of online assessments. We also have video resources for our webinars. We have a content hub, a telepractice page, and a YouTube channel. If you have not subscribed to our YouTube channel, I would highly encourage that. Okay. And then if you want to contact us by email, you can also contact us through our website, and we will get back to you via email. Okay. Now we're going to turn off the PowerPoint screen, and we're going to get to the questions. So I appreciated your presentation, Dr. Goldstein. One of the things that really resonates with me is when we are making sure we're looking at things through the child's eyes. Someone had a question about how they can incorporate that into the evaluation and how they can report that kind of information to parents and teachers.
Sure. So if I showed you one of my reports, it begins with a reason for the evaluation, and then a list of the procedures, and then background information, which is the history that I take from parents that I narratively describe. Then the scoring and summary of the questionnaires completed by whatever stakeholders assist me. Then an observation of the child during testing. And finally, in the assessment results, the reports of the scores. And the last thing that I have is a section titled Clinical Interview. Mm-hmm. And I narratively describe what the child tells me about themselves, about their world. Again, it is qualitative, not quantitative data. And it's a fascinating phenomena because our field has pushed very hard against qualitative data. In other fields, like social work, they operate mostly on qualitative data. Psychiatry, qualitative data, the description that's provided by the patient or the client to the professional. And yet in our field as psychologists, we've been admonished to stay away from qualitative data. It's not reliable, it's not accurate, it's not valid. Well, it has a place. And so in response to the question, I would encourage you to take the interview and the background information from the parents, qualitative data. It has a place, and narratively put it into your report.
So you just kind of do a play-by-play description of the conversation and what their point of view is.
Right. I'm old school in the sense that I dictate. So, and I still dictate because it's faster for me, and I'm competent at it. So I'll have the history form and I'll just dictate through what the parent told me. Or I'll have the clinical interview and I'll say, during the clinical interview, when asked for 3 wishes, Billy wished for this, this, and that. When he asked for clarification, he told me he thought he could never have those things. I asked him what his favorite thing to do was this with his family. And this is right. It's just a narrative description.
Gotcha. So if you have a diagnosis from a previous provider that you don't agree with, should you consult with them first? How do you usually handle that?
So let's make sure I understand. So, because sometimes parents come for second opinions.
Okay.
And they come for second opinions because something didn't sit right with them with the previous evaluation. Sometimes it's a really good evaluation, but a very poor explanation of how the evaluator arrived at their conclusions. And the parents are kind of left not understanding why the professional said that. Sometimes it's that the parents feel they haven't been heard. They'll say, I told them all these other things, and this was the only thing they focused on, right? And sometimes it's the parents just disagree. They feel like the evaluator didn't listen to them or didn't really understand their child. There's a variety of reasons, and I always try and clarify that up front because I try not to be, I am a New Yorker, so I'm critical of everybody, but I try not to be unfairly critical to another evaluator who may have had their reasons. So second opinions, yeah, and a lot of times the second opinion that I offer is not a lot different than the first opinion.
Right.
I take parents through and help them understand why. Sometimes it's not, because some of our colleagues will make diagnoses based on questionnaires. And you well understand that on a Basque or a Connors, a child based on parent and teacher response could be elevated on 10 different diagnostic scales. And then the evaluator gives them 10 diagnoses. Well, that's
right.
not good. Questionnaires are not a good place to end. So it depends why. And in some cases, I'll tell you just quickly about a case from earlier this week. A child was diagnosed, I saw when he was 6. He has all kinds of behavioral and developmental challenges, but I didn't think fit criteria for autism, even though on the ADOS he struggled, but he had other reasons for it. I said it's social pragmatic. A treating facility, a day program, gave him the ADOS and said, nope, he has autism, which then that's how he's been treated. And that's what the school is serving him as. And now he's 13. Mom wants me to do a reassessment. And I just did. And he still doesn't have autism. But he has a lot of social pragmatic problems. He's got the developmental delay. He's very oppositional. Right. So I try and explain to parents, all right, so I'm not going to take the autism diagnosis away because he's receiving services for it. I didn't make it, but I'm not going to steal it away. This is not a contest. So
right. I think your point to we're saying earlier today is that you have the tool does not make the diagnosis. The evaluator makes the diagnosis. You have to look at everything. But given all that information, would you go back to the previous evaluator and have a conversation just about what their impressions are before you formulate your impressions?
And that also depends on chronology. You know, if the assessment was done 3 years ago, I typically don't, I want to see the report, but I don't necessarily reach out to the provider. Mm-hmm. If it was done a year ago, then I will ask parents. In a lot of situations, parents will say, no, I'm uncomfortable. I don't want you to call them because they're concerned about conflict. Or now let's switch. Let's look at treaters. I receive a lot of referrals from counselors and therapists and behavior managers and ABA therapists. And there, I either ask for an email or I get on the phone with them and I ask them to really help me understand what questions they want answered. Not why did they make the referral, but what questions are they hoping to answer with my input? And then afterwards, I try and go back to them and say, okay, I can answer these, or even after this, I still can't answer this question.
Okay. So let me follow it up with this. Can you have people here on this webinar from a variety of settings. Some are hospital settings, some are school settings, some are clinic settings, private practice, et cetera. So this question is, can you discuss how to make assessment work best within a framework where multiple meetings and interactions with the parent are not possible? Like, for example, in a hospital setting where assessment often needs to be done with the child in 1, maybe 2 visits.
Well, and my response to that is, you have to tailor what you do to the circumstances that are to the setting.
Right.
So yes, I like to spend more time with parents and really understand chronologically what the history's been. Sometimes I'll take a history and we'll make another visit before I even see the child. On the day that I take a history, I don't see the child. A lot of health insurances require me to get a prior authorization. I can take a history, but I can't see the child without a prior authorization. Some don't, but I still like to get a history without the child present. Even for younger teenagers, I want the parent to feel comfortable to communicate with me. So if I'm in a school setting, I understand parents are reticent, because I've been there. Parents are reticent to give us the history we need to really understand the life of the child, because they feel it's a school. We don't need to tell you about this. We don't need to tell you about our family mental health history. We don't need to tell you about, and you respect that, and you do the best you can within the framework that you have to operate. In a lot of settings, in an inpatient setting, kids are evaluated while they're in the inpatient setting, and there's minimal feedback that occurs, with parents. I think you adjust your assessment process and the questions you're comfortable answering to the setting that you're in. Here, I'm speaking about the best of all worlds. You create the setting that you think is the one you want to operate in.
Yeah, so you try to strive, you're giving what is ideal, but maybe not exactly what you can always do in the setting that you're in.
And when you say you can't do it, that doesn't mean you do nothing. And when you say you can't do it, that doesn't mean you abandon trying to come up with some data that will help move the child's treatment forward. No, you say within this context, here's what I can do.
Can you provide some guidance on discriminating between OHI and ED when a student engages in behaviors related to ODD and conduct disorder?
So for people who don't know, we're talking about IDEIA, special education law, in the schools. We're talking about eligibility, not necessarily diagnosis. They typically do not have access to the breadth and scope of information needed to make diagnoses. Can they do it? Yes. But should they do it? No. And in some states now, school psychologists are being asked to do Medicaid evaluations within the schools and use these diagnoses. And there are a number of programs for those people who are interested, between 20 and 28-hour online training programs where you're trained in how to use the DSM. You have to be trained in how to use it or how to use the ICD, the International Classification of Diseases. So now let's backtrack. OHI, other health impaired. ED, emotional disturbance. BD, behavioral disturbance. The states have come up with some of their own categories. So they rename something. Some states call it emotional. Some states call it behavioral. Of all the categories, all but one describe the problem: behavior disturbance, language disorder, learning disability. But OHI describes the cause: other health impaired. And to get a classification of OHI, you have to have, typically in most states, a physician's letter saying the child has a medical impairment that substantially disrupts their functioning at school. Now, ADHD falls in that category. Why? Well, I don't know why, but it's in there because ADHD wasn't made its own category. There was advocacy for ADHD in the revision of special education law to be its own category, but that didn't fly. So now coming back to your question, how do you make the distinction? I think it's on an individual basis. And sometimes it's very frustrating. In one state that surrounds Utah, it doesn't matter how disturbing the child's behavior is. They call it a conduct problem. And unless the child is not just not doing their schoolwork, but can't do their schoolwork, they don't qualify for special ed. They don't qualify for any help. They're conduct disordered. That's their problem. It's not it's a strange system.
It's an age-old discussion that school psychologists, I happen to be a school psychologist now for 24 years, and it's a discussion and debate that happens among school psychologists: conduct disorder versus emotional disability or emotional disturbance, how it's referred to in some states. But I just want to add, as a school psychologist, you know what your skills are, you know how to practice within your ethics and according to your state and the rules under IDEA. So you evaluate and identify with the team the disabilities that are laid out in IDEA. So right. One thing I was gonna talk about is, do you think there's any value in treating skills such as executive functioning that's mildly impaired if the overwhelming primary issue is anxiety?
Okay, and just one last thing I will add so people understand what we were discussing a minute ago. The history of the diagnosis of conduct disorder by psychiatry is fascinating because, as I mentioned, it's a limited set of behaviors. It's not every problem that will end a youth up in juvenile court.
Right.
So it's a funny thing as a diagnosis. But putting that aside, so let's start with anxiety is a lack of confidence in predicting outcome. You're not sure if something's going to turn out. It could be a trait. You could be genetically driven to it. Could be experientially driven because things don't ever work out for you. Could be some combination. Let's suppose you have trouble with planning in a Lurian definition of planning, which is an executive function, right? Executive functions are any behaviors you use to improve performance. Anything that improves performance is under that umbrella. Planning, attention to detail, emotional regulation, they all improve performance, right? So the question is, planning, being able to be at point A and see how to get to point B, see a way to go. Kids with planning problems, if you look at the Kaufman or Arcas They have a hard time doing that kind of activity. So I'll tell you something interesting. Among kids with anxiety, there's a higher rate of measured planning problems, and vice versa. So I don't think one causes the other, but I think if you're vulnerable to worry, then when you begin to feel stressed, it's harder to see the path forward. And if you have trouble seeing the path forward, then you're more prone to worry a bit because you don't seem to get anywhere. So I think there's a bidirectional relationship. I think it's different genetics, but kids with anxiety tend to have a higher rate of planning problems. It's not pathognomonic. We don't use it to make the diagnosis or prove the disorder. But I've been impressed in my clinic how many times I see that relationship where kids with planning will score at the second percentile and have a lot of anxiety. And when you ask them, when you're feeling nervous in this situation, how do you get from where you are to being someplace where you're less nervous? They don't have a clue.
Well, that concludes our Q&A session. Thank you, Dr. Goldstein, for the webinar today. Everybody is thanking you in the chat box. I just want to let you know there's a lot of kudos for your presentation today.
Okay, that's always good to know.
Yeah, and we hope to have you back in the future. And again, I really appreciate your time, Dr. Goldstein, and it's always a pleasure working with you on these webinars. And thank you all for attending today.
Visit WPS today to start unlocking potential.